Yes, hello. I would like to welcome everybody. Welcome in the name of SOE and welcome you to that first Oculoplastic webinar. It is Lelio Baldeschi and myself, Lelio from Brussels and myself from Munich, who are guiding you through that afternoon. Can you start, please, presenting Ganga Sundar's presentation?
A very good day, everybody. It's my honor and privilege to be invited to this wonderful Oculoplastics webinar organized by the European Society of Ophthalmology. I bring you greetings from Singapore and the Asia Pacific societies that I represent. We only all wish that we lived in the good old days where we could travel, meet our friends, get inspired by our teachers and mentors, and build wonderful relationships with friends around the world. My personal thanks to Professor Christoph Hinsche for his kind invitation to share our experience on Dacryoendoscopy in lacrimal practice today. These are my disclosures, but do not have any conflict of interest related to what I'm going to mention in this presentation. But I also like to acknowledge the contributions made by major treatises and textbooks on lacrimal surgery, which I encourage all youngsters to go through. Lacrimal drainage disorders are very common and significantly affect the quality of life. There are several newer advances in the means of understanding and technology, including Dacryoendoscopy and endoluminal duct recanalization. This is even more important in this COVID era where we are striving towards minimally invasive procedures, where we are able to either perform these procedures in isolation or in combination with other technologies and techniques. I'd like to pay tribute to the legends of dacryology, most of whom we have met and got inspired either directly or indirectly and have made huge contributions to the field of our understanding of lacrimal disorders. Lacrimal disorders, the obstruction disorders, can be broadly classified into anatomic, which is the vast majority of patients that we manage, and the functional disorders itself. But once in a while, we do have patients who have a continuum between anatomic and functional obstructions itself. One of the terminologies which is not well mentioned in our literature is the concept of dacryostenosis, because it's neither all or none, but partial obstruction and multiple level obstructions, which can cause intermittent or permanent symptoms itself. And the treatment for a lot of these lacrimal drainage system obstructions was the DCR, be it external or endoscopic. These are quite mutilating procedures, especially it involves having an osteotomy done either through a transcutaneous approach or transnasal approach. And this is sometimes seen as a one-size-fits-all procedure, which in the modern days of targeted therapy is not that popular. A lacrimal drainage system obstruction is diagnosed both based on entity and the location, upper or lower system obstruction, whether it's a stenosis, is it a complete obstruction with fibrosis, or the occasional dacryolysis itself. And vast majority of them are diagnosed based on history, symptoms and signs, and a combination with lacrimal irrigation, the soft stop, the hard stop, the natural regurgitation, so on and so forth. And once in a while, the use of various imaging technologies, including a DCG. Dacryoendoscopy is something which is not really new. It has been in force for over 25, 30 years. Dr. Emmerich from Germany, Dr. Toru Suzuki from Japan, and Dr. Ray Havate have all been practicing this in one form or the other, from whom I've drawn a lot of lessons from. Just as how nasal endoscopy has completely changed the way nasal endoscopic surgery and nasal endoscopic diagnoses are being made, even for our lacrimal patients, lacrimal endoscopy is bound to change the way we understand and practice diseases itself. So we now believe the use of the endoscope makes it possible to see the pathology within not just the nasal system, but the lacrimal system. These are the various lacrimal microendoscopes that are commercially available, which I've seen and used. And we tend to use the polydiagnosed at this point of time because it's readily available with high resolution. Interestingly, it is made by a company from Munich, Germany. And these are the kind of images that we can get to see with the use of a lacrimal endoscope, picking up various cases of complete stenosis causing symptomatic obstruction, minimal symptoms with nice wide diameter of the nasolacrimal duct with those rugose mucosal folds, a patient with chronic dacryocystitis with mucopurulent regurgitation to lacrimal sac and nasolacrimal duct, and a patient with distal end obstruction with complete nasolacrimal duct obstruction. Here's a patient where the use of a diagnostic lacrimal endoscopy is useful, showcasing narrowing or dacryoendoscopy in the upper part of the lacrimal system. But as you move further down into the nasolacrimal duct, you will realize that the lacrimal duct itself is nice and broad, but the distal end, there's a complete obstruction itself. Sometimes you can use the endoscope to pick up even abnormal pathology, including the presence of foreign bodies, presence of lacrimal stent causing obstructions, and the occasional dacryolyth. Pictures courtesy Dr. Toru Suzuki. And we now are thus able to understand various lacrimal pathologies by looking into the lumen of the lacrimal system proximally in the upper part of the system, into the lacrimal sac, into the nasolacrimal duct, where you can see a stenosis like this, or near complete obstruction of the lower end, as you can see over here. So dacryoendoscopy is something that we originally were performing in the operating theater under general anesthesia, but we are now migrated towards offering it as an outpatient procedure using endoluminal anesthesia without any regional infiltration or general anesthetic procedures itself. Here's a patient where we've shown a relevance of a dacryoendoscopy in a patient with chronic dacryocystitis, whereby where you enter the canalicus, which you will see in a moment, you can see the canalicus itself is quite stenotic and narrow, as you can see over here. And as you move down the canalicus into the lacrimal sac itself, you can see it's a nice dilated lacrimal sac. And then you go into the nasolacrimal duct with these mucosal folds. Because of the stasis, there's always mucus retention with secondary infection, which results in a lot of mucopurulent material that you can see within the lacrimal sac itself. And a good amount of inspection will also be possible when you're actually not passing the endoscope into the lacrimal system, but actually withdrawing it. This is the distal end of the nasolacrimal duct showing a complete obstruction. And as you're withdrawing the endoscope from the lacrimal system through the nasolacrimal duct, you're able to better appreciate not only the dimensions of the lacrimal system, but the associated pathologies, if there's any. Not all patients with NLD obstruction and dacryocystitis have very wide or narrow lacrimal duct systems itself. And as you can see over here, as you move your endoscope back into the lacrimal canalicus, you can see the luminal pathology itself. What do we do along with the lacrimal endoscopy? It now helps us identify the location of pathology, whether it's a diffuse or a complete obstruction, or a focal obstruction or multifocal obstruction, and combine it with endoluminal duct recanalization procedures, which can be done purely as a mechanical procedure or using the various technology, including microdrills, trephination, cautery, radiofrequency device, or laser. I tend to use the mechanical procedures itself. Here's a patient where we're demonstrating the complete process of using the instrumentation for diagnostic and therapeutic purposes. We go through the history, followed by an examination. Of course, the gold standard examination, apart from the fluorescein dye disappearance test, is the lacrimal irrigation, where you're able to show regurgitation of mucus and mucopurulent material, as you can see over here, which tells you usually a distal level obstruction, if necessary, can be confirmed by the presence of a dacryocystogram. We then perform an office or operating theater lacrimal endoscopy, where again we're showing the narrowing of the lacrimal canalicus, and we enter the lacrimal canalicus. You can make out the junction of the canalicus and the sac can be sometimes narrow, edematous, and you enter the nasolacrimal duct. And as you move down the nasolacrimal duct, you can identify a distal end obstruction, which can be overcome. Here's an external view of the same lacrimal endoscopy of another patient, showing the edematous mucosal folds, dilated lacrimal system with mucopurulent material. And as you can see over here, you can overcome the obstruction mechanically using a lacrimal endoscope withdrawn into the sheath of the catheter and enter the inferior meatus, establishing recanalization. This can then be followed by a balloon dacryoplasty if it's a focal or lower end obstruction, using the 90-second and 60-second cycles ×2, as seen over here. You can combine it with an inferior turbinoplasty, and then you can follow it up with bicanalicular intubation, as we do in about 80% of our patients. So these are the adjuvant procedures we do in combination with endoscopy as a diagnostic procedure and endoluminal duct recanalization as a therapeutic intervention. 80% of our patients end up having bicanalicular intubation. 20% of patients require balloon dacryoplasty, About 10% of them require inferior turbinoplasty, which helps postoperative monitoring of the inferior end. And most importantly, the concept of assisted patency described by Dr. Suzuki, where we perform recurrent lacrimal irrigations every 3 to 4 months in these patients as a long-term follow-up. So who are the patients we perform lacrimal endoscopy? We believe it should be ideally performed in all patients with acquired nasal lacrimal duct obstructions, primarily prior to doing a DCR, and secondarily for diagnostic if necessary. And of course, the limiting factor will always be the very young children because the diameter of the endoscope is about 1 to 1.1 millimeters. So in summary, advantages of lacrimal endoscopy include direct visualization of pathology intraluminally, the nature of mucosal obstruction, whether it's proximal, distal, or multifocal, associated foreign body if there's any. There's a better understanding of the nasal lacrimal duct obstructions. It no longer is a blind probing anymore, it's a vision-guided probing, which is what ophthalmologists should be practicing, and lends itself to offering minimally invasive procedures such as ELDRs rather than one-size-fits-all dacryocyst rhinostomy. This is a spectrum of lacrimal drainage procedures we still do. There are still a high number of patients with chronic dacryocystitis, with diffuse dacrystenosis, who have had multifocal obstructions where we still do an endoscopic DCR, but a good proportion of patients end up having endoluminal duct recanalizations. And this has changed, converted half the potentially external or endoscopic DCR patients to ELDR patients. So in summary, I would like to close with saying that be not the first by whom the new is tried, nor yet the last to lay the old aside. Let's embrace new technology, have a better diagnosis rather than a blind procedure that we do sometimes for our patients. Understand and diagnose lacrimal drainage obstructions better. Be familiar with normal and pathological anatomy, including the variations. Have awareness of the various pathological entities, not just all of them are primary acquired nasal lacrimal duct obstructions. Know the appropriate indications, use appropriate technology to deliver the best outcome possible. Thank you very much, and I bring you greetings from NUH in Singapore. Invite you all to our 36th anniversary conference. Thank you very much.
So, Ganga, thank you very much for this presentation. I'm afraid we will go further with the next presentation. It is Gert Görling from Düsseldorf, who's going to give a presentation on Fornix reconstruction. Do you hear me, Gert?
Yes, I can hear you and I can see you.
And I just wanted to mention for all the participants, you can try to send your question and answers just by the function F&A. Thank you.
Dear colleagues, dear chairperson, thank you very much for inviting me to speak on Fornix reconstruction, established and evolving techniques. This is our department, and it's a good example of a lot of Fornixes, because the Fornix in Roman architecture is actually this arc structure in a triumph arc. But today we're talking about the Fornix in the eye, and this is formed by the conjunctiva extending from the lid margin up to the Fornix and back to the corneal limbus. Stephen Kay's group recently established that the conjunctival stem cells are predominantly located in the medial and inferior fornix. And I did this by staining for ABCG2 and P63 alpha, which are the stem cell markers here highlighted in brown, and they can be found as indicated in the nasal and inferior part of the fornix. So the fornix is the stem cell reservoir. What are the indications for Fornix reconstruction? Now, there are a number of diseases causing Fornix obliteration, trauma, tumors, but very frequently cicatrizing conjunctivitis is a result of inflammation, skin diseases, but also drugs such as in glaucoma causing pseudopemphigoid, or oculocutaneous syndromes such as the real mucous membrane pemphigoid result in Fornix reconstruction. Here's an example of a patient with mucous membrane pemphigoid. You can see here that he has some basement membrane deposits of antibodies highlighted in this direct immunofluorescence, causing this inflammatory process and Fornix shrinkage in the lower lid. He maintains good visual acuity at 0.8, but when this disease is progressing, the skin grows onto the cornea, leading to a fully calcineized and vascularized cornea and reduction of vision down to perception of light. When we want to reconstruct the cornea, we need a healthy conjunctival surface. brought you here 2 cases of thermal or alkali burns, a 20 and 54-year-old gentleman. They had 360-degree stem cell failure, as you can see from these preoperative images with highly vascularized and cloudy corneas. Note that in one case with thermal injury, there was a number of oral mucous membrane grafts before, while in this alkali burn patient, there was only stem cell failure of the cornea. The conjunctiva looked rather normal. And in both cases, we performed the very expensive holoclar transplant, which consists of taking a little stem cell biopsy from the conjunctival, from the corneal limbus of the uninvolved fellow eye, expanding it on fibrin gel, and then transplanting this clear 100,000 K graft onto the corneal denuded surface. And here you can see that in the case with severe conjunctival changes and all mucosal graft, this holoclar graft of corneal stem cells failed. Only in the area where there was a healthy conjunctiva, also transplanted from the fellow eye, from the healthy fellow eye, some regular cornea could be seen. While in the patient with a normal looking conjunctiva, the corneal stem cell graft maintained perfect corneal clarity with very little neovascularization over a considerable longer time. So good conjunctiva allows corneal reconstruction and corneal limbal epithelial cells to maintain a healthy surface. So when we want to reconstruct the conjunctiva and we want to use graft materials, the basic principles and we need to remind ourselves of is that the conjunctiva consists of stroma and epithelial cells lining its surface. For Fornix reconstruction, we therefore need such a stromal carrier matrix, which is lined by epithelial cells. If we have an acellular matrix, we need host stem cells, a reservoir, for example, on an amniotic membrane to maintain a stable conjunctival surface in the long run. The matrix itself will determine the biomechanical properties. For example, a stiff matrix will lift the lower lid, reducing exposure, while the cellular component will then decide whether we need to apply immunosuppressive treatments. If we have an allogeneic stem cell from a donor, we need immunosuppressants, while if we use allogeneic autologous stem cells from the host itself, then we don't need immunosuppressives. Standard materials are usually taken from the mouth or the nose or amniotic membrane. Bulbar and tarsal conjunctiva is rather limited. From the mouth cavity, we can use labial or hard pellet grafts. These contain no goblet cells and will not supplement tear film, but we can use labial minor salivary glands, which will provide some lubrication. When we use mucosa from the nose, the terminate can be used for extremely dry eyes because this contains goblet cells and will support an ocular lubrication, while the septal cartilage is rather rigid and can be used for lifting the lower lid in lid retraction. The amniotic membrane, as mentioned already, it has no cells, so we need a stem cell reservoir. It's rather fragile, but we have ample supply and we can use it for large defects. When we want to reform a Fornix, such as in this anophthalmic socket, we need to remove all scars and control inflammation so that the graft are not shrinking due to recurrent inflammation afterwards. Oral mucosa can be used to cover defects such as large as 2 centimeters. We can use full or split thickness grafts from the lip, as I told you already. Then we have to avoid the frenulum or the papilla here. Don't go too close to that, or the midline, because this, if we take hard pellet from the palate, we can induce little fistulas. We don't want that. If we want split thickness mucosa, we need a mucotome, but we can use that to trigger choose the thickness of our graft. We use thicker 0.5 millimeter grafts for the palpebral surface, which is not evident, while we use thinner, cosmetically more appealing split thickness mucosa for the bulbous surface. Both shrink, and this shrinkage or contraction process is most severe in cases after radiation or burns or mucous membrane pemphigoid. In these cases, we use the rather full thickness grafts, which shrink less. With the posterior lamella of the lid, we can also have to address aspects of the anterior lamella. For example, in this case with leschtosis, we did an anterior lamellar repositioning, as you can see here. If we want to reconstruct an entire lower lid with a free oral mucosal graft harvested from the lip, then we have to supply some vascularization to this, which can be done by skin flaps. You can see here several skin flaps used to cover this oral mucosa, and this can then reconstruct a full lower lid defect 1 month post-operatively, a good cosmetic result. Now, alternatively, if we have very, very large defects, such in this case with an orbital invading squamous cell carcinoma facing the threat of orbital exenteration, this can also be excised rather than exenteration. But then we have a large conjunctival defect. This can be covered with large amniotic membrane grafts, specifically prepared for this purpose. And this will work because there is plenty of regular conjunctival stem cells remaining from the remaining conjunctiva and the lower fornix that is here maintained. And this case here is 4 years out, has good vision, has good cosmesis, and a normal looking conjunctiva. But we all know in cases of mucous membrane, while we have early on success in the long term in pemphigoid patients where there are no stem cells left, this will result in recurrence in the absence of stem cells. And also amniotic membrane, as it is rather thin, will shrink or dissolve. But Dane et al. Recently reported on the use of ultra-thick amniotic membrane from the umbilical cord, which offers better stiffness and rigidity and dissolves less fast than the regular and transparent amniotic membrane. If you have a fancy laboratory, you can use cultivated oral mucosal epithelium that is expanded ex vivo on amniotic membrane to cover such large conjunctival defects. Here you can see the post-op result. We know now from a small group from Japan of 16 cases that in thermal cases with 10 years follow-up, they survive. No conjunctival shrinkage is observed, but in cases with inflammatory conditions, as is ocular secretion pemphigoid, half of the cases showed severe recurrence of the fornix shrinkage and scarring. If you don't have such a fancy laboratory here, such as in the case with advanced mucous membrane pemphigoid, you need to think of other options. This eye was blind. The fellow eye was developing severe cataract surgery. We had to reform the lower fornix, which was fused to the close to the pupil or the visual axis. In this case, we grafted oral mucosa to the back of the lower lid after removing the adhesions to the cornea. We covered the cornea with an amniotic membrane graft. This allowed the oral epithelium grafted with the oral mucosa to expand on the amniotic membrane to form a stable epithelium. And then some months later, we could perform through the clear upper half of the cornea successful cataract surgery, leading to improvement of vision from 0.1 to 0.3. Then there's also a group of 7 cases with this technique reported by Sheffer-Tseng recently, and he showed that this could be successfully used to reconstruct and improve visual acuity in 7 out of 7 cases using exactly this technique with an oral mucosa to cover the back surface of the posterior lamella and an amniotic membrane to cover the bulbar surface. But he also showed that these cases preoperative with severe corneal stem cell failure showed recurrence of stem cell failure with recurrence of neovascularizations and opaque corneal epithelium postoperatively. So this oral mucosal epithelium expanded on amniotic membrane growing on the cornea will remain cloudy, as is the conjunctival epithelium, and it also will result in recurrence of corneal neovascularization. I'll ultimately show you a case of a patient with mucous membrane pemphigoid. In this case, we had performed osteodontokeratopacesis, giving this patient a vision of 0.5, despite recurrence of angular blepharon, and we had to address secondary glaucoma, and we did this by implanting a Baerwald implant. And for this, we went straight through the lid margin because the lid margin was fused to the oral mucosa. And we dissected ourselves onto the sclera, implanted the Baerwald, implanted the supratemporal fornix, then placed the little tube through a little incision into the anterior chamber behind the keratopacesis. And at the very end of the procedure, we closed the incision again, repositioning the lid margin straight to the keratinized oral mucosa. There's no fornix. Now, intraocular pressure is reduced due to the Baerwald implant, and visual acuity maintained at 0.5. So let me conclude. The fornix is the stem cell reservoir. For conjunctival reconstruction, this is a prerequisite for corneal reconstruction. We need acellular matrices. If we use acellular matrices, we need stem cells, either from the host or a donor reservoir. And this is particularly important in amniotic membrane transplantation. Oral mucosa is still the gold standard for conjunctival reconstruction. We can use oral mucosa with minor salivary glands for severely dry eyes to give them some lubrication. We can alternatively use amniotic membrane and combine this with oral mucosa to expand the epithelium. But this is okay for conjunctival reconstruction. It will not allow corneal reconstruction. In any case, we need to control inflammation to prevent recurrence and contraction. And in the severest cases, we need keratopacesis surgery to bypass any fornix or opaque cornea. And ultimately, I'd like to remind you that the fornix in later Roman years turned into the brothel, which were working at night in those arcs. Thank you very much for your attention.
So, Gert, thank you very much for having taken over a very difficult topic within ophthalmic plastic and reconstructive surgery. And we would like to give you the questions from the audience, but there are no questions at the moment. Coming to your talk again, the idea of having a artificial conjunctiva, this is for me or for all others has been the dream. Talking about these expanded conjunctival layers. So, do you think they are working as we would like them to work? Because the amniotic membrane was a bit disappointing. So is that something for general, or is it only for very specialized centers like, our Japanese colleagues?
Now, for one, there is no commercial product available. So you need an approved laboratory facility that is allowed to working to good manufacturing principles. So you need a highly specialized laboratory that is appropriate for producing advanced therapeutic medicinal products. And this is not provided in many places. And ultimately, so this, even in Germany, there is not a single laboratory that has the approval to produce such grafts. That answers your question, I think, easily. But what is the long-term perspective? We have this Holoclar graft now, which is produced in Italy. And this is working in specific situations in the cornea, as I showed and demonstrated, when there's good conjunctiva. But a lot of cases in the trial for approval of this product failed because of bad conjunctival situation. So ultimately, it will be our goal and also our duty to convince industry that the conjunctiva is important enough to maintain visual acuity, so that somebody starts producing such a product at very large costs to be able to then later perform corneal reconstruction and to bypass such destructive surgery as keratoprosthesis surgery. That's a personal opinion, but I think that's pretty much true.
So thank you very much. But there are perspectives, but obviously there's a long way to go. I would like now to give the microphone to Lelio. Maybe he has a question to Ganga. Otherwise, he's going to introduce the next session. Please.
Yes, Christoph, thank you very much. Can you hear me?
I can hear you.
Okay. Well, a question to Ganga is interesting, very beautiful talk, both of them, Ganga and Gerd. Actually, Gerd offered us. We met Gerd 30 years ago, and he was offering 30 years, a distillate of 30 years experience. Actually, 3 years each minute of his talk. It is great, actually. It's great to have the privilege to hear all this information. Well, concerning Ganga, I would like to ask him if he have any experience. He emphasized the irrigation of the lacrimal system, and I want to ask if you have any experience concerning the difference that there are by irrigating the system with saline or maybe with viscoelastics. Viscoelastics are quite an anti-inflammatory, let's say, agent. They inhibit the factor that inhibit the migration of macrophages, so they favorite the decrease of inflammation following any surgical maneuver. So Ganga, do you have any experience, or you have experienced any difference by irrigating with viscoelastics or irrigating with saline at the end of your procedures?
Great question, Lelio. Personally, I've not tried experiencing or tried irrigating with viscoelastics. The only time I used to do it was initially when I was going through my endoscopic DCR learning curve. We wanted to inflate the lacrimal drainage system to have a large dilated lacrimal sac and proximal nasolacrimal duct. In terms of lacrimal irrigation, yes, in the past we were doing it more as a diagnostic procedure to find out about the soft stop, the hard stop, the nature of regurgitation material, to kind of find out whether it's a proximal or distal obstruction. And there were patients once in a while where we used to overcome obstructions with forced irrigation. And surprisingly, as you probably all remember, that there's a fraction of patients who remain completely asymptomatic after irrigations. But in terms of post-drainage procedures, endoscopic or external DCRs, we don't do lacrimal irrigations at all because you can view directly with the nasal endoscope the fluorescein flowing through. But the post-ELDR patients where we have done an endoluminal lacrimal duct recanalization, those are the ones we do forced irrigation on a regular basis every 6 weeks or every 3 months, because we strongly believe that there has to be some kind of constant flow through the nasolacrimal duct to keep it patent. Otherwise, as the patients grow older, the tear production is less, the stasis within the nasolacrimal duct, which causes obstructions, recurrent obstructions.
Thank you. Thank you.
Thank you.
Well, I think that now we are ready with the discussion, unless there is any other question. And so we can go to the next presentation. It is my pleasure to introduce my two good friends, Caterina Ponto and Marta Perez Lopez, that will present to us the tale of IgG4 related orbital disease and Graves orbitopathy. Please, Caterina and Marta.
Dear colleagues, dear organizers and friends, I feel very honored to be invited to this webinar, and especially I'm very happy to give this talk together with my dear friend Marta, and the title of our talk is The Tale of IgG4 Related Orbital Disease and Graves Orbitopathy, and I have the easier part because I will show you a very instructive case of our multidisciplinary orbital center. So this is a 55-year-old patient with Graves' disease and associated orbitopathy. He was a severe smoker, and when he came, he was hyperthyroid, although he had already received radioactive iodine. And as you can see on the photos, he had a severely inflammatory active disease with a CAS of 6 points. And fortunately, at this point of time, he did not have any signs for optic neuropathy. So what did we do? We gave him anti-thyroid drugs. We told him to stop smoking, and we prescribed him intravenous steroids, which he should receive by his family doctor for 12 weeks, and then we wanted to see him afterwards. But it turned differently. He already came back after 3 weeks because he had recognized a severe deterioration of his visual acuity. And this was really objectively true. He also had a relative afferent pupillary deficit. And because we suspected optic nerve compression, we performed some imaging. And in the MRI, we did not find a direct compression of the nerve, but a stretching of both optic nerves due to severe exophthalmos. So we took the patient into a hospital where he received high doses of intravenous steroids every second day, and we did further blood tests. So in the serum, we found very high levels of thyroid stimulating immunoglobulins and also high levels of IgG4. And after having had 8 more infusions of methylprednisolone, there was no significant improvement. The disease was still very active, the orbits were very tight, and optic nerve dysfunction was still present. And therefore, we discussed what to do next. And in order not to lose more time, we decided for orbital decompression surgery. This is the finding again before surgery, and this is 4 weeks afterwards. And you can see immediately that the disease had completely inactivated, and in parallel to this, there was a complete recovery of optic nerve dysfunction. So in the workup, we discussed possible risk factors for his poor response to the standard therapy. He was a male, he had male sex, so this is already one risk factor you cannot influence. He was a smoker, and it's sometimes tough to tell patients to stop smoking. He had received radioactive iodine, and he also had high levels of specific autoantibodies. He had an orbital compartment syndrome, or what we call orbital congestion, and he had high levels of IgG4 in his serum. I have to say, when I did this decompression surgery, I also performed a biopsy of orbital fat and of his enlarged lacrimal gland, but this was negative for IgG4 positive plasma cells. So he only had a positive serology. So IgG4 is what we are talking about today, and therefore we have to say that there really seems to be a coexistence of GO and IgG4 related orbital disease in some patients. And what we should ask ourselves is this a new subtype of GO, and when should we measure IgG4 in Graves orbitopathy patients? Should we do it in all patients? Should we do it if they don't respond to the standard therapy? Should we do it in patients with optic nerve dysfunction? And should we measure IgG4 in the tissues when we perform surgery in these patients? So these are the questions I'm now asking my colleague Marta, and I'm really sad not to be able to call her up to join me on the stage, but I'm very excited about her answers that she will give us now in the more scientific part of our talk. Thank you.
Good afternoon, I'm Marta Perez, and I will try to give answer to some of the questions that came up after Katharina Sponto's presentation. IgG4-related disease is a fibrous inflammatory disease characterized by high serum IgG4 levels with a typical histology where we find IgG4 positive plasma cells and lymphocyte infiltration and swelling in different organs. Recently, it has been described that a small proportion of patients with Graves' disease present with high serum IgG4 levels, and those patients tend to be males, they have a low echogenicity in the thyroid gland, they have a good response to the antithyroid drugs, and they tend to become hypothyroid with the treatment. Those patients also have a higher prevalence of orbitopathy compared to the group of IgG4 negative patients. For some authors, IgG4 high levels would be a risk factor to develop Graves' orbitopathy. Finally, up to 37%, but around 20% depending on series of patients with Graves' orbitopathy have high IgG4 serum levels. And those patients tend to be younger, they have a stronger family history of autoimmune thyroid disease, and there's a good correlation between IgG4 serum levels and TRAP levels. Those studies have also shown that in those patients with higher IgG4 levels, it's also high, the CAS clinical activity score is higher, and they have a more severe course of the disease. In this paper, where it was analyzed the clinical and radiological features of Graves' orbitopathy patients with IgG4 high levels, the authors found that all patients were active, that they had a bilateral orbital involvement and quite a symmetrical disease, and only in one patient, infraorbital nerve enlargement was found. So attending to the data we have so far, we could guess that we are facing a new subtype of Graves' disease and Graves' orbitopathy with high serum IgG4 levels that may not be part of the spectrum of IgG4-related disease, as in any of those patients, other organs have been involved. However, to confirm this, we need more studies assessing the histology of the orbital tissues of this subgroup of patients. There has been some research assessing orbital inflammatory disease histology, and in any case, in thyroid eye disease patients, IgG4 plasma cells were found. But in those studies, the tissues were taken from the orbital fat, and we know that it would be more accurate to target extraocular muscles or lacrimal glands if we want to evaluate IgG4 cells. Therefore, in one hand, we would have IgG4-related orbital disease that clinically will affect lacrimal glands, causing a bilateral enlargement, extraocular muscles, mainly the lateral rectus, and could also cause infraorbital nerve enlargement. In a high percentage of these patients, we also find other organs involved and clinical manifestations. In another hand, we would have a subgroup of patients with Graves' orbitopathy and high serum IgG4 levels that would be mainly active patients with bilateral and symmetrical orbitopathy. And we could also find both conditions coexisting in the same patient, as we know that many autoimmune disorders overlap. So to differentiate between both conditions, an orbital biopsy would be needed. And in the first case, we would find IgG4 positive plasma cells that would be characteristic of the IgG4-related orbital disease. And further studies will have to describe what is the histological features of the Graves' orbitopathy patients with high IgG4 levels. To conclude, measuring IgG4 levels could be helpful in new diagnosed Graves' disease and Graves' orbitopathy, as it looks like there's a subgroup of patients with Graves' orbitopathy and high IgG4 levels. And those levels correlate with the activity and severity of the disease. So we need to define the clinical significance of these high IgG4 levels, but we could think, for example, of a different response to treatment in those patients, as for example happens with the rituximab. Finally, to differentiate between both entities, especially in those patients with an atypical course or some features that overlap with IgG4-related orbital disease, a biopsy is needed to differentiate both of them. Thank you very much.
Thank you, Caterina and Marta, for this bright and very straightforward presentation on a very actual topics. It is now the turn of our colleague from the States, Professor Susanne Freitag, that will talk about new insight and result of Teprotumumab treatment in Graves' orbitopathy. Susanne, please.
Hi, I'm Suzanne Freitag. Thank you so much for the invitation to talk to you today about Teprotumumab. These are my financial disclosures, and Horizon Therapeutics is the manufacturer of Teprotumumab. So these are some of the many faces of thyroid eye disease, and these are moderately severe cases in my practice. And as you can see, this is a very devastating disease, both physically and psychologically for our patients. And we've been challenged since the beginning of time on how to manage these patients. Unfortunately, we had a big breakthrough in January 2020 with our treatment options, and that is because of Teprotumumab. So this is the first and only US Food and Drug Administration approved drug for thyroid eye disease. It's a fully human monoclonal antibody. It inhibits insulin-like growth factor 1 receptor. It's for the treatment of moderate to severe thyroid eye disease and has very broad FDA approval indications. The mechanism of this drug is as follows. Overexpression of the IGF-1 receptor is a known key pathological feature of thyroid eye disease. The IGF-1 receptor interacts with TSH receptor, leading to the inflammatory cascade that we're familiar with. Teprotumumab binds to the IGF-1 receptor and inhibits this cascade. It's an intravenous drug infused every 3 weeks for 8 doses. The biggest logistical issues are that the drug is very expensive and it requires insurance authorization, which can be very challenging. Also, it requires arranging an infusion site or home infusion for these patients. The phase 2 and 3 clinical trials were published in the New England Journal of Medicine, and the setup and the outcomes are quite similar. So I'm going to skip to the phase 3 clinical trial and very briefly go through the results. 41 patients were receiving the drug and 42 received placebo. These are the outcome measures. The darker black line is drug. The gray line is the control group. So you can see there was a significant response for the following: proptosis response, change from baseline in proptosis, diplopia response, reaching a clinical activity score of 0 or 1, overall response, and change in baseline in quality of life. The contraindications to this medication are pregnancy, breastfeeding, and in children less than 18 years of age. A relative contraindication is inflammatory bowel disease like Crohn's disease or ulcerative colitis. We use it with caution in people with diabetes. It drives up the sugars in diabetics and pre-diabetics, but they can be managed with increased doses of their medications. So let's look at this in the real world. So the real world right now is just the United States where the drug is available. And I'm one of the largest prescribers of this drug and have a good clinical group of patients receiving this. I prescribe and manage the drug myself. I don't rely on a rheumatologist or endocrinologist or other physician to prescribe and manage. Before the first dose of medicine, we get a serum glucose and hemoglobin A1C because of the risk of elevating blood sugars. We also get an audiology baseline test. These receptors are present in the ear, and we'll talk about ear changes in a moment in these patients. And then just before each infusion, we do a quick finger stick glucose and a urine pregnancy test if relevant. The clinical trials included patients only with active thyroid eye disease, and no patients in the trial were treated for compressive optic neuropathy. Currently, in my experience and in published cases, there is utility with this drug in compressive optic neuropathy due to thyroid eye disease and chronic thyroid eye disease. I'd like to present a couple of patient examples showing some different clinical scenarios. The first is a 68-year-old woman with hyperacute new onset thyroid eye disease. She was a recent smoker. She had restricted movements in both eyes with double vision, a clinical activity score of 10 out of 10, Hertel measurements of 30 and 31, and compressive optic neuropathy with inferior visual field defects in both eyes. Here is her picture straight on and in the various directions of gaze. You can see she has an incredible amount of edema and erythema of her ocular surface and her eyelids. She's very uncomfortable. Here she is after 2 of 8 Teprotumumab doses. Her TEL measurements went from 30/31 to 23 and 26. Her optic neuropathy has completely resolved. Her clinical activity score was 2 out of 10. Those points were just for her pain and pain with eye movement. You can see the external signs of inflammation all look so much better. And here she is side by side before and after 2 doses. And here is CT imaging before treatment. You can see she has very enlarged extraocular muscles on both sides. And on the bottom left, you can see that her orbital apex is crowded by these large muscles. And then after 8 doses, you can see that the muscles, although slightly enlarged, are very significantly improved, and her orbital apex is not crowded. So this is a different patient. She's 55. She has new onset active thyroid eye disease, but a very different phenotype. When you push on her globes, there's significant resistance to retropulsion. Her orbits are just totally inflamed and hard, and she's having a lot of pain and feels absolutely miserable. After 4 doses, she came in saying, "I feel and look like myself again." And here she is after 8 doses. So for her, this was sort of a factory reset back to her normal baseline. Next, I'd like to show a 72-year-old man. He was diagnosed by multiple physicians as having allergies. And he came to see me, and I was suspicious for thyroid eye disease. He was proptotic, 28 and 27. He had restricted eye movements in both sides, things that are not really consistent with allergy, and his thyroid functions and antibodies were abnormal, consistent with Graves' disease. So I met him prior to the FDA approval of Teprotumumab. So he was initially treated with 12 doses of IV steroid, didn't help, got rituximab 3 doses, really didn't make any difference either. And then he got Teprotumumab, and you can see that his festoons of lower lid edema are shrinking up. His proptosis is reduced several millimeters, 24 and 24 after 3 doses. Now, he's definitely going to still need some lower eyelid surgery, but we're putting out the fire finally for him. When deciding on thyroid eye disease treatments, it's important to understand what the different treatments will do. Each treats a different constellation of findings. And so I've made a list of common signs and symptoms, and I've used a traffic light coloring. So green means that these things are likely to be fixed. Yellow means may be fixed, and red is not going to be fixed by the various treatments. So this slide is looking at steroid. So if we're giving steroid to a patient with thyroid eye disease, I would expect their active inflammation to get better, their pain, the conjunctival and eyelid changes. They might have an improvement in their eye movements. They might have an improvement in lid retraction. They may have a reduction in their eye pressure, and their compressive optic neuropathy may be helped. I don't expect it to melt the fat, the roof hypertrophy, the steatoblepharon, the proptosis. I would not really expect steroid to fix that. So let's look at this same list for Teprotumumab. It is not good at fixing upper eyelid retraction. It can help, but I tell patients you may still need to have your upper eyelids fixed, and sometimes lowers as well. It's a mixed bag for fixing double vision. For people who have mild restriction of eye movement, it can fix that. For people who have an eye that's stuck down or in, it's not likely to completely resolve that. It is likely to decrease the extraocular muscle size. We're finding that in almost all of our patients when we do CAT scans on them. So it's helpful to know what your treatment is going to be expected to do so you can tailor it to your patients. So what about chronic thyroid eye disease? This is a patient of mine who had severe disease and then has been inactive for about 4 years. She underwent multiple eyelid surgeries because her eyes were prolapsing in front of her lids, but she did not have an orbital decompression because she was worried about double vision. So pre-treatment, she was 28 millimeters on her TEL, and after 2 treatments, she's at 24.5 and 25. You can see that the upper eyelid ridge of fat is melting away, and she says when she feels her eyelids and when she pushes on her globes, everything is much softer. And I agree. So what about adverse reactions? I just recently calculated in my own patients the reactions, and I think it's very similar to what was published in the clinical trials. So in my patients, 96% reported adverse reactions as mild or tolerable, and a lot of these patients really had no adverse reactions. 55% did have muscle spasms, usually in the calves of the legs. 36% complained of ear changes. Now, the most common ear changes are a mild buzzing or tinnitus, sometimes in one ear, not both, and sometimes unilateral or bilateral muffled hearing, like getting off an airplane or having some pool water in your ears. I've had 3 or 4 patients who've had some pre-existing sensory neural hearing loss, which they feel did get a little worse on the treatment. We've stopped the treatment in one patient and are considering stopping in another because of concern about her hearing. About a third of the patients complain of nausea and fatigue. Some have a change in taste. Some of the younger women have diarrhea. I've got a few people with brittle nails, and about 8% of my patients were diabetic or pre-diabetic, and their sugars did go up. In conclusion, Teprotumumab is a powerful addition to my armamentarium of thyroid eye disease treatments. It's effective in moderate and severe thyroid eye disease, and very few patients are non-responders. It can be rapidly effective in acute thyroid eye disease and effective in quickly reversing compressive optic neuropathy. It can be effective in chronic thyroid eye disease even years after the acute phase. Radiographically, it reduces extraocular muscle size and proptosis, and clinically reduces proptosis and periorbital eyelid fat. We used to tell patients with moderate to severe thyroid eye disease that they should expect that they would never look the same again. For many patients, this is no longer true. Thank you.
Thank you, Susanna. Very nice talk, and very much looking forward to have this drug also in Europe in a way to help better our patient. I just look at the question and answer, and there is some question concerning the clinical significance of the diagnosis of IgG4 associated with Graves orbitopathy. So eventually Marta or Katerina can answer. So when you suspect a possible association, since it is, let's say, important clinically to be able to use rituximab, for instance, instead glucocorticoids alone, do you, at this stage, do you advise to take a biopsy, possibly of the muscles or of the tissue that can be involved, like the lacrimal gland?
Maybe I'll start. So I would not do a biopsy of the muscle because it's more invasive. But of course, if I see an enlarged lacrimal gland and I do eyelid or decompression surgery, then of course I would do the biopsy. But the more easy thing is to test the IgG4 in the serum. And we do this now quite in the daily routine, especially when the case is not completely normal. So maybe Marta can add something.
I agree.
Okay.
And
well,
I think that if you are not...
Please, Marta, please.
I was just going to say the same, that if you're planning surgery and the clinical course is not typical, then it's easy to take a biopsy. But if a patient has all the, I mean, if you're thinking that it may be an IgG4 because it has something different, and also the levels in serum, as Katharina said, are high, then it should, as you said, it should be necessary a biopsy, and probably from the lacrimal gland, which is more easy to take.
Right. Well, a few years ago, when we start talking about orbital IgG4, I still remember I received one paper from some friends from Australia, where it was said that in the case of monolateral orbital disease, well, you don't have a systemic one, therefore it was not possible to find alteration in the blood. While in the case of bilateral IgG4 orbital disease, you might find also alteration in the blood. You can have a rise titer of IgG4 in the blood. Did you have any experience of suspect Graves orbitopathy and IgG4 disease monolateral?
No, we don't have, because I have had several patients with both diseases or an associated disease, but as far as I remember, no monolateral diseases. What I see more often is patients having IgG4 related serum markers, but rather atypical orbital disease when they have additional Graves disease. So they don't really have an orbitopathy like disease with eyelid retraction, for example, but only the typical signs of IgG4 disease associated with Graves disease.
Okay, thank you, Caterina. I saw also some other question for the second talk, the one on Teprotumumab. And one recurrent question is about ototoxicity. Suzanne, can you tell us more about this complication? Which is the frequency of such a complication in your practice?
Sure. My adverse effects slide was the data from my practice. So we had about 36% of patients with ear complaints. But the vast majority of those complaints were not sensory neural hearing loss. So the vast majority of patients have a buzzing in one or both ears, described as similar to tinnitus. And some of them also have a clogging or muffling of the sound, which is different than a hearing loss, but more like if your ear needs to pop after being on an airplane. And that is an intermittent finding. Some people say it's more common first thing in the morning and gets better during the day, but it's not something that's always present in these patients. And we know that the IGF-1 receptors are present in the ear. And so it would make sense physiologically that the medication could be affecting these receptors as well. Now we have a few patients who had some baseline sensory neural hearing loss on their audiology testing, which they were aware of as well. And these patients have gotten worse during the course of their treatment. One of them got a lot worse, and so her treatment was stopped. I'm fighting with another patient right now whose hearing is clearly worse, but she doesn't care. She's so happy that her eyes are getting back to normal that she wants to continue with the drug. So that's a whole nother level of ethical discussion. But we are having serious conversations with our patients with existing sensory neural hearing loss. And in fact, I just turned away 2 patients recently who agreed with me that they did not want to risk further sensory neural hearing loss. And so a lot more will be discovered about this as we look at our audiology testing data, and other centers are also doing the same.
Okay. And now a question of mine, the effect of Teprotumumab, either the side effect like hearing loss, but also the positive effect like exophthalmos reduction or increased eye motility and inflammation, are lasting long, or they are somewhat reversible? They last for a while, but then there is a recurrence of disease.
So
in other words, sorry.
Sure.
I was saying.
So I currently have 120 patients enrolled for the drug. Most of them have started their treatments. Many of them have finished their treatments. I am retreating right now 1 patient out of my patient population. She did very well So she was a hyperacute patient, sort of like the first patient I presented. Her double vision and her optic neuropathy resolved with 1 or 2 doses of the drug. She completed 8 treatments. She did great. She felt great, but she still had upper lid retraction. So we waited 7 months after her treatment was completed. She was absolutely stable. And at 7 months after treatment, I did upper lid recessions internally, and I did blepharoplasty of the upper lids. And for the first 2 months after this upper lid surgery, her disease reactivated. It reactivated to the point that her lids were swollen and inflamed, her conjunctiva was inflamed, her double vision came back. So she was able to get retreated. She's had 2 doses now, and she once again has had a rapid resolution of her reactivation. So I have to wonder, given the timeline, if my surgery may have set her off. And if that's the case, should we adopt a different way of thinking about doing surgery before we were waiting as long as possible for these eyelid surgeries after disease deactivated? And now I'm wondering if we should do our surgeries sooner while we still have drug on board. So there are a lot of questions to still be answered, but I'm moving toward earlier surgery for my patients now for their upper lids.
Thank you, Suzanne. I think that Christoph wants to ask you a question. Please, Christoph.
Oh, thank you. Susan, yes, the cases you presented, they were absolutely, yes, amazing. And we all know that the earlier usually we treat, and that's with the steroids the same, we're treating active disease. What I just couldn't understand, how would you explain an effect in long-standing chronic cases with this drug?
I think we may have to redefine what we're calling chronic. Maybe chronic patients they're chronic from a timeline perspective, but maybe chronic doesn't mean inactive. Clearly, however this drug is working, there's still something going on in order for these patients to get better. So, and it's not only good at putting out the fire of the inflammation, but it has a remarkable ability to shrink fat. And I think that's one of the biggest differences between this drug and our traditional anti-inflammatory therapies like steroid or the other immune modulators. They're good at putting out the fire in many patients, but the roof hypertrophy and the fat pads in the upper and lower lids just don't shrink up in the same way they do with this drug. So I think, it's a very different mechanism, but I think that we have to wonder, is it working on this other fat mechanism, or is there still actively inflamed tissue in what we're defining as chronic thyroid eye disease? I think we need to be careful about how we use these words now. And I think we're going to have a little different paradigm of thinking about this disease activity as we learn more.
Thank you very much. And I would like to thank you, all the 3 speakers of that session. And I am happy now to announce Lelio himself. Lelio Badeschi from Brussels, and he's going to present a special actual case. Lelio, please.
Good afternoon, everybody. Dear Christoph, dear colleague, thank you very much for this kind invitation. The challenging case of today concerns a patient affected by Graves orbitopathy who received an mRNA vaccination anti-SARS-CoV-2. The prevalence of Graves orbitopathy in Graves disease is about 50%. Of this 50%, only 3 to 5% of the cases has a sight-threatening disease. Sometimes the threatening disease is refractory to glucocorticoid treatments, and the orbitopathy can worsen despite administration of glucocorticoid. In very severe case like this one, there is even orbital fractures, and the great congestion that follows can be treated with extensive bone decompression, like in this case. Bony decompression can restore the high congestion that was present at the beginning. But as you can see here, also in the most severe cases, in the most severe congestion, the redness of the conjunctiva and the perikeratic injection never reach the sclerocorneal limbus. That's a typical sign of Graves' orbitopathy. When you see redness and perikeratic injection reaching the sclerocorneal limbus, it might be that you are dealing with a carotidocavernous fistula, like in this case. Recently, I came across a patient with similar symptoms to the previous one. So, severe perikeratic injection reaching the sclerocorneal limbus. That was weird for a Graves' orbitopathy patient, but indeed, he was a Graves' orbitopathy. He was a male patient, age 43, ex-smoker. Before diagnosis, he was smoking around 20 cigarettes a day. The diagnosis was at the beginning of 2020, and at the moment of my evaluation, he was metabolic stable under anti-thyroid drugs. He was also affected by gout and systemic hypertension. Which was his proximal medical history. In the summer 2020, he received high doses intravenous glucocorticoid that resulted no effective. Later on, in February 2021, he had an orbital irradiation by means of 20 grays in 10 sessions. Again, no benefits. Finally, in June 2021, he received a single infusion of rituximab. No benefits once again. Following the administration of rituximab, he received a vaccination by means of Pfizer-BioNTech mRNA anti-SARS-CoV-2. And he had a remarkable worsening of the symptoms starting 10 days after the vaccination. When he came to my observation, there was an old MRI done. It was dated December 2020, so it was not possible to assess what was going on in the hot orbit of this unlucky patient. So I ordered an MRI and an angio-MRI with the idea that this clinical picture could have been Graves' orbitopathy and carotidocavernous fistula, or a thrombosis of the sinus cavernosus, as it was described already as a complication of anti-COVID vaccination. It took 3 weeks to have him back with the requested exam, and the clinical picture at that time was greatly deteriorated. He had severe corneal erosions, and the exophthalmos was much more severe than at the beginning. Let's say the angio-MRI was unremarkable. It shows only an agenesia of the left anterior branch of the Willis, and there were no sign of thrombosis of the sinus cavernosus. Looking at the MRI performed in December 2020 and comparing the MRI performed in 2020 with that performed more recently after my examination, there were no substantial differences except for an increase in exophthalmos. Looking at the vasculature of the two MRI, we detect well-defined superior ophthalmic vein in 2020 and ill-defined superior ophthalmic vein the year thereafter. So we hypothesize that a thrombosis partially recanalized was present and was the cause of the symptoms presented by this unlucky patient. Following my first examination, I had the opportunity to see the patient back about 3 weeks afterwards, and the symptoms were severely deteriorated and compatible with an ischemic insult to the anterior segment. Free wall orbital decompression reverse restore the elevated intraorbital pressure and repristinate a proper venous drainage. Up until now, I just described the clinical case, but what had happened to our unlucky patient? Well, since April 2021, it is known that virus-based vaccination, such as AstraZeneca, is connected with an elevated risk for induced autoimmune thrombotic thrombocytopenia. It is also known that this type of thrombosis is different from that which is induced by mRNA vaccination, such as Pfizer-BioNTech. In our unlucky patient, however, the administration of rituximab 1 month prior to the administration of the Pfizer-BioNTech has created a thrombocytopenia that might have triggered the occurrence of the thrombotic event, in fact mimicking an etiopathogenesis similar to that which takes place in virus-based vaccination. Finally, conclusions are suggested by a recently published article. Every kind of vaccination against SARS-CoV-2 can lead to adverse and severe vascular events, including thrombosis. However, the risks to develop such an adverse events are much higher in the case of infection by wild SARS-CoV-2 virus. I think I reached the end of my talk, and I thank you very much for your kind attention. Hope to see you very soon in person. Bye-bye.
Thank you, Leo, for this specific singular observation. I'm not sure whether we will have the time for some questions, but at that stage, we are going to introduce our very last speaker today, last not least, David Verity from London, who will present on the challenge of sphenoid wing meningioma. David, please.
Good afternoon, ladies and gentlemen. My title is The Challenge of Sphenoid Wing Meningioma. The sphenoid bone is an unpaired one in the middle cranial fossa, with the central body containing the sella turcica, 2 greater wings forming the anterior parts of the middle cranial fossae, and the lesser wings making the posterior parts of the anterior cranial fossae. The cleft between the greater and the lesser wings form the superior orbital fissure, and the clinoid processes are important features of the sphenoid bone in skull-base surgery. Now, sphenoid wing meningiomata are centered on the sphenoid wing, and 20% of all intracranial meningiomas are indeed sphenoid wing meningiomas. They are slow-growing, and they originate from the outer arachnoid meningeal epithelial cells. The World Health Organization defines 3 grades. 90% of them are grade 1, and these do not invade the brain parenchyma. Grade 2, on the other hand, show frequent mitoses and an increased nuclear cytoplasmic ratio, and it includes atypical variants. And the more aggressive grades 3 and 4 show more mitoses, necrosis, and invasion of brain parenchyma. But the point to remember from this slide is that 90% of all sphenoid wing meningiomata are grade 1. Now, for patients presenting with sphenoid wing meningioma, they may do so in 3 separate ways, with a mass effect, vascular congestion, or visual impairment, or a combination of all 3. Patients present with globe displacement, reduced movement and squint, or distortion of the globe with change in their refraction. They may also present with vascular congestion, as seen on the bottom right of the slide, chronic conjunctival chemosis, and dilated episcleral vessels. And visual impairment can occur due to exposure keratopathy or compression of the nerve either in the orbit or behind the orbit. Now, the radiology shows that meningiomas can occur on the inner and the outer aspects of the sphenoid wing with bony and soft tissue components, as shown on this slide. And the spectrum of presentation can vary from being an incidental finding to congestion and optic nerve compression, as previously mentioned. Bone involvement occurs in 30%, but 12% can be primary intraosseous involvement. And very rarely, there may be bilateral disease, as you see in this patient, with tumor extending into the orbital apex and through the orbital fissures. In this case, soft tissue is also seen in the left temporalis fossa and in the middle cranial fossa. Now, the treatment of sphenoid wing meningiomata is challenging. These diseases are not curable, but they're containable. And we monitor the patient and consider orbital decompression, where there is neuropathy or significant proptosis, or subtotal resection with neurosurgical colleagues, where there is a significant cranial component. Radiotherapy is indicated, and we consider that for grade 1 tumors where they are inoperable or where there is progression. The indications for grade 2 are less certain, but there's a strong case for radiotherapy, and in grade 3 tumors, radiotherapy is indicated even after complete resection. I'm going to present 3 cases, the first being the 60-year-old gentleman who presented with a very gradual onset over 7 years of right-sided proptosis with reduced visual acuity of 6/9, subjectively darker color vision, a grade 1 relative afferent pupillary defect, and 6 millimeters of proptosis, as you see on the left of the slide. His radiology confirmed hyperostosis of the bone, crowding at the orbital apex, and where there is some doubt about the tumor, we should not forget that a gallium dotatate CT-MR image has a role to play. These tumors express somatostatin receptors, and radiolabeled gallium avidly attaches to this receptor, and this can be harnessed in terms of a gallium dotatate scan, very useful where there is diagnostic uncertainty or where subtle recurrence is suspected. An example of a dotatate scan is seen on the left of this slide. So this patient underwent a lateral wall decompression, and although these are not images from his surgery, they serve to show how we approach the lateral wall through an upper lid skin crease on the left, exposing the lateral wall, reflecting the periosteum over the lateral wall as shown here, and then removing a large section of the bony part of the lateral wall or a lateral wall fenestration as shown with an oscillating saw here, and the fenestration has been created and the soft tissue lies behind the malleable and as yet the unopened periosteum. But in this patient, you see here his perioperative images. As a reminder, the imaging at the top, and you can see here the residual part of the lateral wall after much of the bony and soft tissue components have been removed. Here you see a bony fragment being removed, and on the right in the middle here, you see the soft tissue components being removed. And we undertook this with the Elman radiofrequency cautery, just demonstrating the significant amount of soft tissue, but by no means all, that was removed in this particular case. So the gentleman was kind enough to keep post-operative photographs and to allow us to use these, and these show quite significant chemosis in the first 48 hours, but beginning to resolve by 1 week and 2 weeks, and finally resolving a number of months later. But he underwent surgery for both his proptosis and his reduced visual color appreciation. So how did he fare Well, you can see that the visual acuity improved, and remember that he underwent a lateral debulk, not a medial. But despite this, his subjective color appreciation improved, as did his relative afferent pupillary defect, as did his proptosis by approximately 4 millimeters. I have a second case to outline some of the challenges involved in such patients, because this gentleman presented with a history of prostatic carcinoma and a lesion at the posterior part of the lateral orbit, as shown on the slide on the left. And he had 4 millimeters of proptosis, reduced color appreciation, and a relative afferent pupillary defect. And I'm showing here the 3D soft tissue reconstruction, because the lesion is in blue and the optic nerve is colored pink to purple, as you see here. And look how the lesion is kinking the nerve as it travels around the back of the orbit. And you can see at this point here just how constricted the nerve is around the lesion. So without yet a diagnosis, we undertook an incisional biopsy through a lateral canthotomy, once again using the radiofrequency cautery as shown here, and the pathology identified a grade 1 meningioma. So what would be the next step? Well, again, we considered a medial wall decompression because this would carry minimum risk to the patient, and that's what was undertaken. And you can see here the preoperative images, particularly the coronal scans here, and the postoperative, showing a reasonable reduction and increase in the volume of the medial wall. And you might anticipate, therefore, that his color appreciation and his vision would improve. But sadly, it did not, presumably because of the tight constriction of the nerve over this bony bar posteriorly, as shown on the bottom of the slide. And therefore, he underwent further surgery with our ENT colleagues to remove this bony element with improvement of his vision. And my final case, case 3, is a 40-year-old lady who presented with sphenoid wing meningioma, as shown on the top right, but who also had canal involvement. And again, the question would be whether a medial wall decompression had anything to offer in the context of canal involvement per se. And so we adopted, once again, a medial wall decompression via the retrocaruncular approach to the medial extraperiosteal space. So here is the retrocaruncular approach to the medial wall. Here is the malleable retractor retracting the globe laterally. The blue arrow shows the periosteum, which has yet to be reflected laterally, but having done so, exposes the medial wall, allowing us to complete the ethmoidectomy and the posterior orbital floor, in addition to the bone between the two, that is the inframedial bone strut. So let's look at her perimetry before surgery. And here you see in July 2019, with a reasonable set of isopters, but approximately a year later, you can see the inner isopter, which is this smallest one here, has markedly contracted. And so she underwent a medial wall decompression with 4 millimeters reduction in her exophthalmos. And her octopus visual fields, as shown here, show a marked improvement in her inner isopter, but yet it is still not normal and still not as good as her preoperative scans some 2 years earlier. And so the challenge in this patient is to know what to do next. She, in fact, feels there has been a major improvement, and she does not wish for further surgery. And we should remember that quite often intervention for these tumors causes more morbidity than the tumor itself. But radiotherapy may be an option, as may be debulking of the canalicular part of the tumor, because you see on these scans here a reminder of how compressed she is behind the orbit at this point here. So, in summary of this talk, the challenge of sphenoid wing meningiomas. Key points: meningiomas are largely benign. More morbidity tends to occur from treatment of the disease than the disease itself. Where there are no visual symptoms, manage conservatively. Where there is major proptosis or intraorbital nerve compression, consider orbital decompression, either lateral or medial, and that decision is also something of a challenge. Where there is a visual pathway defect with compression posterior to the orbit, these patients may require cranial decompression or indeed radiotherapy. And finally, always avoid progesterone treatment because this drives the evolution of meningiomas. Finally, radiotherapy helps to slow down disease progression, and its role and timing in management of these diseases is still being understood. Thank you very much indeed for your attention.
So, David, thank you very much for this very clear illustration of a difficult topic, as we all know. And since now we are in the situation, we are running a bit late, but we are allowed 1 or 2 questions or remarks if they are there. David, there's one question which actually doesn't refer really to the meningioma of the wing, but the question is optic nerve sheath meningioma. Is it usual to have good vision despite significant proptosis on presentation?
Well, thank you, Christoph, and thanks everybody. These diseases behave in different ways, of course, and so it is possible to maintain good vision despite a large tumor volume. Don't forget, a lot of the loss of the vision in sphenoid wing meningioma is due to compression, and therefore in the absence of compression, these patients can maintain good vision. But sphenoid wing meningioma and optic nerve sheath meningioma have different biology and different behaviors.
Yes, very nice to point that out. And there's one other question. Would signs of orbital inflammation rule out a differential diagnosis of optic nerve sheath meningioma?
I don't think so, but don't forget that congestion can look like orbital inflammation, just as Lelio and others have so well pointed out. We must never confuse the two.
Thank you. So there are no other questions from the floor. And so I think Lelio and myself, on behalf of all the speakers, would like to thank the participants. It was a kind of east to west. We started in Singapore, Germany, we had Belgium, we had England, Spain, and the US. So it was a kind of wide spectrum. And I hope you find or you found these talks interesting and helpful. And with this, I think I would like to thank everybody. And I would like to make one last remark. There are some open questions which couldn't be answered, and we will try to get the speakers to come back to you if you give your address. Is that everything fine with you? Okay, then thank you very much and have a nice evening or good night.